Hello, everyone. It is officially 3 p.m. and we are live both on Facebook and via Zoom with our webinar on realizing uninterrupted sexual and reproductive health and rights during the COVID-19 pandemic. Over to our director who will facilitate, Felicita Hikuam.
Thank you, Hejin, and good day, good afternoon to everyone in Eastern Southern Africa, and good day to the rest of the participants who join us from other regions. We will wait 1 or 2 more minutes just to accommodate anyone else that's still trying to find the web link and trying to join us. And we will start officially in 2 or 3 minutes. Please bear with us. Thank you. Good afternoon again. Now that we have more than 30 people joining us, we will begin our webinar. Thank you so much and welcome to this webinar titled Realizing Uninterrupted Sexual and Reproductive Health and Rights During the COVID-19 Pandemic in Southern and East Africa, which is hosted by the AIDS and Rights Alliance for Southern Africa. My name is Felicita Hikuam, and I'm the director of the AIDS and Rights Alliance for Southern Africa, also known as ARASA. I have the honor of welcoming you all to this webinar and moderating the discussion this afternoon. Before we get started, we have a few announcements to assist with your participation in this webinar. Firstly, you can follow the session in English, French, and Portuguese. To access the language channel, please look for the interpretation icon at the bottom of the Zoom meeting or the Zoom webinar box. The interpretation icon you will find is next to the chat box icon or the Q&A icon. When you click on this icon, on the interpretation icon, you can choose the audio channel for the language of your choice. You can mute original audio to only hear the interpreter. Please note that all the speakers for this session will speak in English, so there will be no need to switch between channels. Please also note that this webinar is being recorded and will be uploaded on the ARASA website, our YouTube channel, and other social media platforms. This webinar is also now being live streamed on the ARASA Facebook page, and you can feel free to share it on your social media from there. We encourage you to be mindful of revealing any personal particulars and other information, including your name, your age, affiliation, or country, if you are not comfortable for this to be public. You can also click on the 3 dots in the box with your profile and select rename to change your name if you do not want your name to be visible to others. Please also note that this webinar is a safe and neutral space for sharing of experiences and perspectives in a mutually respectful manner. ARASA has a zero tolerance policy for any kind of bullying, harassment, abusive use of language, aggressive expression of opinions, or any such undesirable behaviors. Anyone who engages in such actions will be immediately removed from the session without prior notice. Lastly, we will not make use of the raise hand function or allow participants to speak directly during this session. But we do encourage you to please feel free to share your thoughts, your comments and questions in the Q&A text box, the chat box, or in the Facebook comments section. Due to security reasons, unfortunately, your engagement in the chat and or Q&A will not be anonymous. Now that we have all the announcements out of the way and behind us, a little bit of background to this session. For those who've been following our webinar series, this is the second webinar in a series of webinars that ARASA is hosting to reflect on promoting a rights-based response to COVID-19. I will outline the upcoming webinars at the end of this session. For those who are also new to ARASA, we are a partnership of civil society organizations working in 18 countries across Southern and East Africa, which was set up in 2002, initially to promote a rights-based response to HIV. Recently, we have pivoted strategically to anchor our work in the core principle of the respect for and the protection of the rights to bodily autonomy and integrity in order to reduce inequality, especially gender inequality, and achieve health, dignity, and well-being for all in Southern and East Africa. In particular, we believe that the achievement of sexual and reproductive health and rights in Southern and East Africa depends on the realization of people to have their bodily autonomy, integrity, privacy respected. Over the past few months, East and Southern Africa, as you know, along with the rest of the world, has been reeling from the disruption caused by COVID-19 on the health, lives, economies, and livelihoods in our communities. Not only did COVID-19 exacerbate existing fault lines in our healthcare systems, it also exposed existing inequities in the realization of sexual and reproductive health and rights. Sadly, even before the COVID-19 crisis, systemic sexual and reproductive health rights violations, especially against women in key populations, fueled by structural challenges, including those embedded in laws, policies, the economy, and in social norms and values, persisted across our region. Central to these human rights abuses is a lack of respect for and protection of the rights to bodily autonomy and integrity. But despite this, and as we grapple with the health and socioeconomic outcomes of the COVID-19 pandemic on our countries and communities, it is clear that we need to safeguard the sexual and reproductive health and rights gains we have achieved in the region, as previous health crises have taught us that these gains are fragile and can be eroded quickly. For example, researchers found that during the Ebola outbreak in Sierra Leone in 2014, the closure of clinics and reduced reproductive healthcare services led to between 3,600 and 4,900 additional maternal, neonatal, and stillbirth deaths between 2014 and 2015, compared to 4,000 from the Ebola virus itself during the entire pandemic. Which brings us to this webinar. Over the next hour or so, we will explore what the current situation looks like in regard to access and realization of uninterrupted sexual and reproductive health and rights. We will look at our preparedness, but in our analysis of this, we will particularly focus on the 4 elements of the right to health, which are availability, accessibility, acceptability, and quality, the triple AQ of sexual and reproductive health and rights during the COVID pandemic. We will also use the expanded definition proposed by the Lancet-Guttmacher Commission as our reference to the definition of sexual and reproductive health and rights, along with the expanded package of services they recommend. But to kick us off, we will check in with the perspectives that you bring along to the session to help us frame and ground this session. After this, we will proceed with a panel of distinguished speakers who will help us frame the issues and help us unpack these a little bit more. But now to the check-in with the participants and to everyone that's joined us for this afternoon, we would like to invite you to join us on a platform that's called Mentimeter. It is a polling kind of or survey type of platform on the internet. And we would ask you to open a new window in your web browser. So if you're using Google Chrome or you're using Firefox or whatever web browser you're using, please can you open a new window and type in Mentimeter or menti.com. So that's MENTI.com, menti.com. And those who are joining us through interpretation may also feel free to respond to the questions in their language of choice. So once you have typed in menti.com, please type in the code 9247859. Again, the code is 9247859. We'll give you a few moments to do this and get this done. But if you look on the screen, you should be able to see the same instructions that I have just provided. To go, please, to menti.com and type in the code that's provided at the top of the screen and then respond to the first question, which is which words, and singular words or a few words also fine, which word comes to mind when you think about access to sexual and reproductive health services during COVID-19 in your country? Which words come to mind? And you can enter as many words as you like. Just to explain how Menti works is that the word cloud provides all the words and mirrors all the words that are submitted. The ones that are the biggest are the ones that were mentioned most frequently, while the ones that are the smallest were mentioned least frequently. So they were not mentioned as frequently as the big ones. Interesting to see that when people think about the access to sexual and reproductive health services during COVID-19 in their countries or in their communities, the word limited is mentioned most frequently, followed by rights. I think mortality and primordial, not a priority, are also fairly big, right after limited and rights. But the smaller ones are scary, restricted, difficult, excess, necessary, inessential, which are all pretty similar words to describe a rather dire situation and speak also to the big word limited. There's also now the word political. It's not a priority. Inaccessible is another one that's been used, which is very, very interesting. Another word that comes to mind when people think about SRHR services during COVID is criminalized, really interesting, deprioritized, and discriminatory is another word that I've seen. The ones that are still the largest, limited. So overall, the picture seems to be that sexual and reproductive health services during COVID-19 are limited. It reflects and is linked to rights and the realization of rights. They are essential, but they are not a priority. Those are the bigger words that are coming to the fore. The ones that are smaller, again, inessential, decreased is one that's also come in. Violation is another one. Cannot stop is another one that's come in. We've had 19 responses. Thank you to those people. But limited is still in the lead. Expensive, scary, insufficient, discriminatory, difficult, inessential, primordial, shortages, stigma. They are the smaller words, but they all speak to very similar concepts or very similar sentiments. Rights is also now becoming a little bit bigger. Restricted has also been mentioned several times now, along with not a priority. We will give you about 1 more minute to allow the other people, aside from the 21 who have participated in this survey or in this poll, to submit any of the words that come to mind when they think about access to sexual and reproductive health services during COVID-19 in their countries. Very interesting words. Limited is still in the lead. It is now followed by rights, followed by ignored, restricted, essential, and not a priority. Less frequently mentioned, again, inaccessible, shortages, criminalized, insufficient, decreased, many barriers has also now been mentioned. Traditional, quite interesting, insufficient. Oh, there's one that I can't read. It's in red, but I can't read it. Sorry, and I'm wearing glasses, but I still can't read it. Violation is another one. So now we have closed voting for this question. We have 2 more questions coming up. To those people who have joined us since we started with the poll, please can you go open a window in your web browser and go to www.menti.com and type in the code 9247859 to respond to the question, which SRHR services are least available in your country during the COVID-19 pandemic and during the COVID-19 response? We've had one very brave person who's dropped in the word safe abortion has been least available in their country and in their community. If this was a face-to-face meeting, I would have given you an award. It probably would have been chocolates, but luckily it's not, so I get to save some money. Now we've had 4 other people respond. The words that are coming up, counseling has come up twice now. Abortion services come up 4 times. Antenatal, prenatal services as well. Gender affirming services for trans people at some point has also now come up, very interesting. Family planning, safe abortion, access to safe abortion and contraception has come up 1, 2, 3, 4, 5, 6 times. So definitely it seems like access to termination of pregnancy services seem to be the least available in communities across our region at the moment during this COVID crisis. Safe abortion is not even legalized generally. Again, maternal health care has been mentioned, contraceptives have been mentioned, counseling has been mentioned, and as I said before, the abortion services are coming up quite frequently. I think it's been mentioned 6 or 7 times in response to this question. Birth control has also now come up because that is linked to contraceptives. So contraceptives are also leading right behind Contraceptives, family planning, birth control are leading behind access to termination of pregnancy and safe abortion. Oh, that is interesting. Now, SRHR education has come up, probably around comprehensive sexuality education. Very, very interesting responses. What's more interesting for me is also the level of consensus and the synergy between the words that are coming up when people think about the least available services in their countries. Okay, we are busy counting down, so we will close this this question and this poll pretty quickly. But again, contraceptives and termination of pregnancy, maternal health care, counseling. Interesting, again, the fact that people have mentioned that abortion was not even legalized before the COVID-19 crisis, let alone being able to access it during the COVID-19 crisis. But also interesting that counseling has come up 3 times because mental health and counseling support is so important to sexual and reproductive health and rights. Okay, thank you to the 22 people who participated in that poll. The next question is, what in your mind is the biggest challenge facing the realization of uninterrupted SRHR in the region during COVID-19? So now we've talked about what we generally think, we've talked about which services are not available, but what is the biggest barrier? What is the biggest challenge that is limiting access to those specific services that you had mentioned? This should be very, very interesting. There was one person who in the previous poll had mentioned that even before COVID, abortion services were not legalized in their countries or were restricted. So it should be interesting to see what specifically is a barrier during the COVID-19 crisis for the realization of uninterrupted SRHR. Lack of political will, lack of prioritizing it, political will. Political will is coming up very, very frequently. It's come up 4 times. Restricted movement and finances. Fantastic, so interesting. Criminalization, red tape, political and ideologies, shortage of resources, financial constraints due to economic downturn. It is not taken as a priority. The designated facilities, or the lack of designated facilities, conscientiousness, objections, stigma, finances, a way to push back women's power, so the patriarchy, stockouts, and funding being redirected from SRHR to COVID-19 initiatives, and restrictions in movement, very, very relevant to the COVID-19 situation. Someone says, COVID-19 just makes it very difficult. That comment has gone away, but I will continue. Oh, it says, COVID-19 has just made it more difficult. There is less political will, lockdown, and socialization. Implementation of the law is one of the biggest challenges facing the realization of uninterrupted SRHR in the region during the COVID-19 pandemic. Financial constraints has come up several times. Restrictions in movement have also come up several times. We have had 22 people respond to this. We are busy counting down before we close this poll, but some very interesting and again, some very similar responses that have come out in terms of the role of political will, the funding situation and financial constraints, the fact that there's a lack of, prioritization, way that, there's been an undermining of women's power, and the patriarchy has also led to some of the challenges. The, interesting has also been things like stigma that were mentioned, but very, very interesting for me, the fact that there's such consensus around some of the ones that are mentioned so frequently, but also how well what you've mentioned in this poll links to the lack of services and the services that are least available in communities or in countries. And I guess, the statement about COVID has made things just so much more difficult. These things were difficult. Access to uninterrupted services was difficult, but COVID has just made it so much more difficult. Seems to sum up pretty well the sentiments that were exposed there. Thank you so much to everyone who has been able to participate in those polls. I really enjoyed the Mentimeter, and it is now bordering on a point where we are abusing the Mentimeter at ARASA, but it's just so useful to check in with everyone before we get into the meat of the discussion and we invite our panelists to share some of their thoughts. It also helps them, kind of frame their thinking and their perspectives in relation to the audience that they have and the people who have joined us for the discussion. So thank you very much again for participating in that Mentimeter poll and and responding to the 3 questions. Now we will move on and continue with the rest of the webinar, which, as I mentioned previously, will consist of a very exciting panel of speakers. They will be joining us from Zimbabwe, Kenya, and South Africa, and will share some reflections and experiences on what is happening in regard to access to uninterrupted SRHR in their countries and communities, but also reflections on what needs to happen to address these challenges and these barriers. Following the panel, I will ask our allies, Boemo, Sekgoma from SADC Parliamentary Forum, and Innocent Modisaotsile from UNFPA, the United Nations Population Fund, working at the regional support team in East and Southern Africa, to just reflect a bit on what our civil society and community partners will share about their experiences and what they are witnessing, what their assessment is of the situation and what needs to happen. And then for them also to reflect a bit on what their institutions should be doing and are doing to help ensure uninterrupted SRHR during the COVID-19 crisis. They'll also speak a bit to what other stakeholders can contribute to ensuring uninterrupted SRHR in the region during this crisis. But to get us started, I would like to welcome the speakers that will join us for the panel discussion, and I would like to ask them to please put on their video when I announce their name, and then also when they are speaking. I know and you can appreciate the challenges that our neighbors in Zimbabwe are facing with connectivity, but we were pleasantly surprised in the previous meeting, a webinar that we had, that the Zimbabweans outlasted the South Africans due to the load shedding situation. So we'll see what happens today. But we will try to kind of prioritize input from Tadiwa, who will join us from Zimbabwe, so that we make sure that she gets her input in before the connections become problematic. But I would like to introduce the panel to you. First, I'd like to welcome Marion Stevens, who is the Director of Sexual and Reproductive Justice Coalition in South Africa. I won't mention their credentials because we are short of time and we really just want to get to the gist of it, but you can find their bios and a little bit about what they do and where they work and how they approach things on our Facebook page and on our social media. We have these flyers with the background of the speakers, but I would like to just welcome Marion Stevens. Hi Marion, thanks for joining us. Then I would like to welcome Shamim Salim, who works for the Church World Service in Kenya. Hi Shamim, thanks for joining us.
Felicita. Thank you.
Thank you
for having me.
Thuthukile Mbatha, who's a researcher at Section 27 in South Africa. Hi Tutu, thanks for joining us.
Thank you for the invitation as well.
And then finally, Tadiwanashe Burukai, who is the Executive Director of Womandla Foundation in Zimbabwe. Welcome, Tadiwa.
Hi, Felicita. Thank you.
Thanks for joining us. Okay, so without further ado, let's get started with this panel discussion, which will be framed around a series of questions that I will pose to the speakers. And each of them will get 3 minutes about to answer each of the questions. The first question, and I would like to propose that we actually start, Tatiwa, if you don't mind, I'd like to get your input in from the get-go. As I said, you know, we are worried about your connection. We can start with Tadiwa and then followed by Tutu. We will then go to Marion and conclude with Shamim. So the first question to the panelists is, what is your assessment of uninterrupted, the state of uninterrupted access to SRHR in your community, generally in your country, or across East and Southern Africa? And when you reflect on the current situation and the current, your assessment and the current state of access to services and generally SRHR, can you also reflect a bit on preparedness? Do you think that the state that we find ourselves in terms of access to uninterrupted SRHR speaks to preparedness to be able to continue and provide uninterrupted services should a disruption such as COVID-19 happen? You know, is that a link, and does that explain it? But what is, you know, just generally, what do you think the situation is like? What are you seeing in your neck of the woods? And what do you think the state of preparedness was to be able to provide uninterrupted services in your community, in your country, or across the region? As I mentioned, I'll start with Tatiwa. Please go ahead.
Thank you so much, Felicita. I'm hoping I'm clear and everyone else can hear me. Thank you so much for joining us. Awesome.
Yeah.
So I'm Tadiwanashe Burukai, as noted by Felicita in the introduction. And in response to the question you had posed to us, the assessment of access to uninterrupted SRH, I'll start by looking at my community. I would say that we were really not prepared as a community. My community is semi-rural. It's a small mining town in the southern region of Zimbabwe called Zishavane. We were not prepared for a pandemic, and the situation placed most of the young people, especially young women, at a risk and at an age. My assessment with regards to uninterrupted SRHR services and provision was, as a community, I would first likely to say that we have one public health hospital, Shawnee District Hospital. That's the hospital that caters for the whole community. And our community has a population of over 55,000 people that reside in that community. And I still remember in beginning of May, we had our doctors and some of the nurses testing positive for COVID, and our hospital had to shut down. And it's the only public hospital that the community uses to access services, health services, inclusion of SRHR services. This was for me a shock, and it placed the whole community in a state of panic, if I should say, because now residents had to access those services at private hospitals and private clinics, which are very expensive, and every average Zimbabwean was not unable to afford those services. So it was a really stressful period, if I should say, and most women were unable to access their contraceptives. They were not able to access STI screening and testing, HIV testing as well, not even to mention for pregnant women. It was, and it still is, in a state of panic, but like at the end of May, after some of the nurses had recovered and emergency nurses were robbed in to come into the community and provide services provisions, the hospital was able to open up and start functioning. So my assessment is that COVID-19 has brought in a new set of new normal, where we are now starting to think about risk management, risk preparedness, where we're looking at how we need to prioritize health, especially SRHR health issues and health service provisions as well. Yes, so I don't want to take most of the other panelists' time as well. So thank you, Felicita.
Thanks, Tatiwa. It gives such a, you really painted the picture of what happened and what your environment looks like, and really drew us into what some of the challenges are that you're facing in your community. I had mentioned that we would proceed with Tutu, I believe. Tutu, can you tell us what's going on in your context and what you think about how prepared the system was to continue with uninterrupted SRHR during the COVID-19 crisis?
Thank you so much, Felicita. I'd like to start by saying, definitely, the pandemic did cause a lot of confusion and interruptions in access to services in many aspects. I remember that at the beginning of lockdown, a lot of people, the pandemic actually imposed a lot of fear and confusion in communities. And not only were the people or the citizens confused, but even healthcare providers as well had the confusion. I remember in South Africa, women, especially around Gauteng, would go to a clinic to access contraceptives or to seek abortion services, and they'd be turned away, being told that, no, that's not essential services. So there was a lot of confusion, of course, and that's when we had to intervene in such cases. And South Africa is not the only one that has seen such interruptions. We've seen that in Uganda, with the ban of public and private transport, we saw a lot of women dying on the side of the road and giving birth on the side of the road, trying to walk to hospitals for them to access healthcare services. We saw in Kenya, hospitals going empty as well because of fear of contracting COVID in hospitals, and more women opting for home births. And we've also seen in Lesotho, with PrEP and other HIV prevention interventions being put aside as non-essential. And that already was putting another pandemic on the rise, and that people living with HIV, or people who want to prevent themselves, who are key population groups, who want to prevent themselves from contracting HIV, were now put aside. So we've seen a lot of interruptions with the pandemic. And I don't think that anyone was prepared for this. I think this caught all of us off guard. Us as civil society organizations were never prepared to not go to the field and interact with the people that we serve. Government, again, never in their wildest dreams anticipated such a pandemic coming and exposing all of their deficiencies as well. So, and again, with the closure of a lot of clinics around the region and people being unable to access services, that already tells us that the state of preparedness didn't even exist. So none of us were prepared for what COVID brought to us. And this had brought concerns around the populations that we serve. For instance, Section 27, and mainly my work, is to work with students and also learners in schools, and promoting the rights to sexual and reproductive health, and also assisting them or equipping them with skills of addressing sexual violence. And that has been the most difficult task to provide, especially considering that the learners that we work with are learners that come from predominantly poor backgrounds, who have no access to social media, no access to smartphones, no access to the internet, who now don't have access to such critical information. And with the budget cuts as well, and the budget reallocations, we've seen that 40 million rands that was initially budgeted for life skills and HIV/AIDS schools program has now been rechanneled towards the COVID response. So that on its own means that CSE is not even on the cards right now. And we know that sex is happening, and adolescents are quite curious beings. So them not having access to information and the interruption in services with the already existing stockouts in South Africa, we anticipate to see a lot more harm in the near future. So definitely we were not prepared from my view, and there's certainly been a lot of interruptions in access to services.
Yeah, it's a very, very dire picture that you're painting, and bringing home the realities of women giving birth on, you know, on their way to clinics, etc. It's very, very dire. Before I proceed and invite Marion to give her perspective, I wanted to just remind everyone joining us this afternoon that we won't be taking or inviting people to speak. So we won't use the raise hands function, but we really encourage you to have a conversation, share your thoughts in the chat box, and also to use the Q&A box to drop some questions that you have for the panelists. So as you listen to the panelists respond to my questions, please feel free to drop your questions or even your perspectives and your experience and what's happening in your context into the chat. We really do want to hear from what's happening. I think it will enrich the conversation so much more. But with that, I want to ask Marion to please share her assessment of what's happening, how prepared we were, and what the general state of access to SRHR services is in your context.
So firstly, Felicita, thank you so much for inviting the SRJC, and thanks to the ARASA comrades for hosting this panel and for continuing a conversation that's so necessary. I want to frame my assessment about preparedness within a reproductive justice framework as a starting point where rights and health are enabled or disrupted within our context of fertility and bodily autonomy that has been governed within a population control framework. And we in the region are feeling that acutely within how health is being reported upon. Why are we not sick and why are we not dying is the one aspect. And then the other aspect is why people are very worried about us because we are going to have a population explosion with little examination of consumption patterns from the north. And so a reproductive justice framework really looks at fertility intentions of people. So enabling people to safely choose to get pregnant or not to get pregnant. And yesterday I met somebody who has chosen to get pregnant during this time and is exercising their choice and will be having a child hopefully safely in November, which is very exciting actually in this horrible time. So there is hope for some people actually in a terrible time, and they have safely been able to get pregnant and looking forward to that. But as people have said in the Mentimeter earlier on, this COVID epidemic has sharpened our focus and our lens on existing challenges, even though within South Africa, where I'm from, we are understood to be developed and kind of better off in terms of legislation and services within the region. We have enormous challenges. And so COVID has sharpened a lens on showing how our information on, as Tutu said, information for adolescents, for everybody, on sexual and reproductive health, reproductive justice is appalling. Even the new kinds of information that's coming out, there's adverts on abstinence in 2020, which we know are to be harmful. There's very poor access to reproductive health commodities. Section 27 does a fantastic job on kind of pointing out some of these issues too. And there's a shortage of supplies of contraception and Gauteng in 2020 in the city of gold. And then participants also spoke about abortion as a real challenge. Now in South Africa, we prized for our abortion law, but we in the private sector in Johannesburg today have stockouts of mifepristone, one of the key abortion drugs. So there are enormous challenges that we have where women and people coming in for services are scared to come into clinics because of illness. So let me leave it at that, Felicita.
It is indeed a very dire situation that you're also reinforcing in terms of what you're witnessing. And I think what you're raising is so important about, and I think it reinforces also what Tutu was saying about this looming crisis, that things are happening right now whose impact we won't see until, 6 months later, a year later. And it really also brings me to mind of like, how should we be intervening, which is something we'll discuss a little bit later in the discussion. But thanks so much for sharing that and also framing it within the concept of reproductive justice. Thank you very much. Shamim, what is happening in Kenya?
Thank you, Felicita. So I'd start with how well or not prepared we were as a country, especially in response to SRHR and COVID. And I'd say, like most other countries, we were not prepared. And even when we started off responding to COVID, there was a characterization of essential services. And SRHR is not seen as an essential services because essential is seen as an emergency. And so it's not seen as emergency when you get pregnant and you want to have a safe abortion, or when you want to access maybe PEP services. And so that has resulted to a lot of impact on generally like everyone, but also more specifically marginalized community, the LGBT communities, sex workers, women, and even young people. And for example, we have seen lack of access to services like getting commodities. In Kenya for the last 4 months, we've not had access to ARVs. There's been like lack of or dramatic reduction of access to ARVs, which is like very, very alarming. And we are also seeing, people not being able to access abortion services. For example, we've had booming cases of teenage pregnancies, and suffice to say that some of them are teen to teen in sex, but then we also have cases of sexual violence in this to these young people, and they cannot access legal services. There's also lack of comprehensive sex education generally in Kenya, but you're seeing now that is needed more. Also, the other thing is realizing that with the lack of ARVs and other services is how resources are now becoming more and more scarce. We are seeing Global Fund pulling out, and other potential partners who are pulling out in supporting SRH as a very important part of our work. And also the other thing is that at this particular time, we are seeing, for example, the LGBT communities with criminalizing laws in place, it's more heightened, right? Because the safe spaces that we have for ourselves, that we have created for ourselves, are no longer there. And so then it presents like a very big gap and a very big challenge, especially for LGBT communities or even other people who benefit from some of these safe spaces. The other thing I'd say is that even at this time, accessing other services, for example, legal services, which then intersects a lot with SRHR and how people access the services. For example, if someone has been raped, they need legal services. But because that's not a priority at this time, then it becomes a very big barrier in terms of how people go out there, even just be and access those services. And I'd say also the issue of mental health services, which is very, very important. As you said, Felicita, earlier before, the importance of mental health in people accessing SRHR services is really lacking. And particularly for some of us who have really benefited from community care and creating those community mechanisms to support each other through, accessing these services, through ensuring that we are safe, even as we, as we go to access. For example, if you are going to have safe abortion, you have a community of support. But with a restriction of movement and all this kind of response mechanisms to COVID, it's a bit more limiting. Yeah, thank you.
Thanks, Shamim, for sharing your experience and also adding into the pot of services that we are noticing, are seriously being affected. this also speaks to what came up in the Mentimeter, but I noticed that you all added a few other services, including comprehensive sexuality education. You also spoke about the needs of marginalized communities, especially LGBTI, but you also spoke to legal services, Shamim, in particular. There was also the issue around kind of antenatal care. Obviously, access to termination of pregnancy and abortion was mentioned several times on the Mentimeter. But it seems to give a really good picture of what's happening across the region that is very similar, that even from the comments that I'm reading, and I've seen there's one comment from Namibia that I'm going to read, but that also reinforces and actually agrees with the experiences that you have reflected from your communities and countries. And while I get ready to read the comment that has come in from Namibia, I wanted to also invite my colleagues to set up the screening of a video that we wanted to share from a colleague in Malawi who submitted a short video to share what's happening in Malawi. And we just thought we could add that to the perspectives that you're sharing from Kenya, from South Africa, and from Zimbabwe, and also just hear what's happening in Malawi. But while we get ready to do that, I'll just read this comment from Namibia that says, I fully agree with Tutu, where we were not ready at all. In Namibia, in the first hard lockdown, commodities such as condoms were not considered essential for the first month. With schools suspended and slowly resuming with work back, comprehensive sexuality education will not be a priority because there's such a backlog in what the students have to cover. And this will leave, and it does leave, a burden on civil society to take up the role to educate young people, even with their own budget cuts. But, you know, they also have a question you know, that we will reflect on later. And I will add that into the mix and get to that later. But for now, let's get the video from our colleague in Malawi and hear what's happening in Malawi.
Hello, how are you? My name is Salim, and I'm a social worker as well as a sexual reproductive health and rights activist, and I'm based in Lilongwe, Malawi. And so when talking about how we can realize uninterrupted access to sexual reproductive health in these times of COVID, so many things come to mind. And the first has to be the fact that I think as CSOs, as governments, as people who are implementing in communities, we need to acknowledge the fact that we already have so many social and structural inequities that are already hindering access to sexual and reproductive health and rights services even pre-COVID. These are issues that have existed and have often been ignored, or people would start working on them and then stop. There's been so much inconsistency in addressing these issues. And so what we're finding now is that with COVID, these issues have just been worsened. And so now we have the situation that is getting out of control, and you know, it's no surprise because it was already neglected, all these structural and social issues. And so I think when it comes to realizing uninterrupted access to sexual reproductive health and rights services in Africa, we first of all need to address this bias. We first of all need to address these social and structural issues that exist. And the other thing that I have to say is that we need to leverage on young people, especially for services that are meant for young people. We need to leverage on young people's innovation. We need to leverage on young people's social innovation and the ideas that they're able to come up with, so that we ensure that we're working with young people and not working for young people, which is very important. And then the other thing I have to say is we need to prioritize it. And if we say we're prioritizing it, it means we're really putting it at the forefront of our planning. You know, we have seen so many responses from different governments across the world when it comes to COVID-19 response. I know, for example, in Malawi, we have the protection responses in education, we have them in health, in PPE distribution. However, not so much is being spoken about how do we ensure that young people are still able to access these sexual reproductive health and rights services. So when we say prioritizing, not just saying it, but actually doing it. Thank you.
Yeah. What a great input that both reflects on challenges that existed before COVID, what we're facing now, but also what needs to be done. And that's where I would like to go in my next question to the panelists. So now that we've kind of dissected what is happening, what does the situation look like, what challenges are we facing, why are we facing these specific barriers, including pre-existing systemic and structural issues? The next question that I have for the panelists, and this will be my last question to the panelists actually, before we move on to our allies and our partners from SADC PF and UNFPA to give us reflections on what you all have shared. My last question to you is, what are the, and I think you've spoken to this a little bit in terms of like the specific areas of concern, but what is being done to address these barriers that have been highlighted because of COVID, some of them that are COVID specific, including what happened during the lockdowns, etc. But what do you think should be done and what is actually being done? You can speak also to what your institution is doing, what civil society is doing, what other stakeholders are doing, but this is now the question about, we've dissected the problems, okay, what's the action? What needs to be done? What needs to be happening? Also speaking to the issue of kind of our preparedness. So how do we learn from this experience and prepare for another disruption that may be coming? Because, there's one thing that's for sure, and that's change. Change is the only constant, they say. So how do we address the challenges we're facing in terms of the interruptions in access to SRH services that are currently happening, and how do we prepare our system to make sure that we're better prepared for future disruptions? For this, I will, if Tadiwa is still with us, I will start with her again, and then we will go to, then we'll go to Marion this time around, then we'll go to Shamim and end with Tutu. Tadiwa?
Hello, thank you. I should get $1 every time I should start speaking, hey?
Next time.
Awesome. So the question was looking at what's being done and what else can be done, and also how to prepare for future emergencies that might emerge again. So looking at what Shamim was talking about with regards to issues of mental health and psychosocial support, as an institution, as Womandla Foundation, we've been having what we call Ask a Recipe. It's whereby we were posting our contacts and emails and numbers around the community groups, and saying that if you're living in a home, in a violent home, probably with a perpetrator who's beating you, who's raping you, issues of GBV and domestic violence, you would text to that number, probably say, can I please get a recipe on how to make grilled cheese or a cup of tea or whatever. The whole point was that you would need to communicate that I'm not staying in the safe zone. So text back, can we call? Can we visit? We would call back and text, and then would get information, and sometimes would report anonymously, because some of the women that would text us were too scared to leave their houses and report. And noting also that the COVID-19 national regulations, we had police roadblocks in the streets and everywhere, so movement was kind of limited. So us coming from a civil society background and organizations, we could have a conversations at the roadblocks and be able to access what we call the victim-friendly unit, which is a department in our police force where they work with women who are also going through issues of gender-based violence. This has actually worked quite well, and we're getting a lot of responses and a lot of texts and calls with regards, and we are actually trying to push forward and continue this, even though the conditions have actually been loosened within the country. And also looking at accessing what we call hygiene and dignity kits. Coming from a rural background and a rural community, not everyone is able to access and afford sanitary wear, be it pads, tapoos, they come in different products, menstrual cups as well. So you'd realize that we were doing a lot of projects with the business community, with well-wishers and donators, where we would be able to collect either in cash and kind and be able to buy hygiene and dignity kits. But then you realize that my community, and I think most communities in Zimbabwe and other countries within Southern Africa can closely relate to how access to water has become an issue. So you'd realize that not everyone was able to access clean and potable, safe water. So part of our dignity kits was inclusion of 2 buckets so that you'd be able to get water and be able to have it at any given time that you might need to access it. One might look at it as a luxury that they be able to open a tap from their home and have flowing, clean, safe and portable water, but you do have to understand that not all communities are the same and not everyone is able to access the basic human right of water. So this is some of a project that we've been partnering with some of the CSOs within the country to actually do a lot of donations with regards to hygiene and dignity kits. So how to prepare probably for a situation like this, that if it might come, probably, and if it might continue, was probably the first of all, we have to, as CSOs, as individuals, as activists, as advocates, feminists, we need to push for our governments to probably prioritize having an emergency budget, our government, to push our government to have an emergency budget. And within that emergency budget, because it would look probably at security budget, it would look at health budget, to have a section that specifically looks at SRHR services and how probably we can make them accessible and affordable during a pandemic period. Is probably having mechanisms and ways of ensuring that despite any situation or any pandemic or any natural disaster that might come within the country, we should be able to say, if this happens, we are able to do this. Looking at example of what happened in my community when our hospital shut down, we did not have a plan B because we had not prepared of such a situation. So people came in a panic mode and people just doing what was nearest to them. Coming from an African society, we all know if the health situation is unreachable, people go to alternative B, which are traditional keepers or cultural gatekeepers, and some of them are not legally recommended to practice. So you realize that it has certain effects to one's health going to that point of life. So probably, as I was noting, that we need to have mechanism, a budget, not just a financial budget, but even resources should be allocated to say that we need to ensure that each and every community, each and every health center has a plan B. That's how we would want to probably claim it, as to have a plan B, that in case of an emergency, we are able to do this and this. And continuous,
Go ahead.
let me repeat up so I could also save them some. And to probably prioritize educating the community. We have governance structures, we have leadership structures, we have elders in the communities, looking at how homogeneous our communities are, but to ensure that education is done from the local level and not from the national level, so that people are informed, educated, and understand what's going on.
Yeah. No, I totally agree. I totally agree with you on that last point. And it makes me think about how much of the COVID response is in and of itself is actually owned by communities. But that's a conversation we can have at another time. We are starting to run out of time. It's 4 minutes past 4. But I do want to kind of conclude the panel discussion and give some time to the respondents who will share their reflections, but then also take some questions. There have been some really interesting comments and questions that have come up, which we will take after we have received the responses from Marion, Shamim, and Tutu. Marion, please go ahead.
Thanks. So I've got 3 things that I want to say very quickly. So there's a huge potential with telemedicine, and we're seeing that in relation to abortion services. I'm not going to say termination of pregnancy, because all pregnancies terminate, not all pregnancies terminate with abortion. And it's good to destigmatize our language. So we're talking about abortion. And there are various groups that are doing it. I am a bit concerned about disaster capitalism, where in South Africa, where you've seen international NGOs flood in and the private sector lead with telemedicine. And we need to get, and that's my second point, we need to get government to mainstream these services and to program for telemedicine, and not to rely on international NGOs and the private sector. We need to make sure that COVID does not undermine our basic public health systems that are going to be for everybody and not for the few. And lastly, civil society needs to organize. And in South Africa, we've been very fortunate with a far from perfect coalition, but a coalition called the C19 Coalition, the People's Coalition, which has brought together groups that don't normally work together. We've had to organize virtually. It's been difficult, but we have tried to thrive and survive and get this together. And it's been fabulous to partner with partners that we don't normally work with. It's been great to have groups like like Section 27 lead on some litigation around sexual and reproductive health. And we look forward to continuing this and to getting that to happen. And part of this is actually working to hold our government accountable, to look to reproductive health commodities, to look at putting in place systems, and not to renege. So very quickly, those were my 3 points. Thank you.
Oh, fantastic. Thanks so much, Marion, and thanks for being so succinct and, but also speaking to the issue of terminology. I think it's so important, and we have work to do within civil society and communities ourselves. So, but we do need to point it out every time that we encounter it, because it also matters how we engage with others outside of our space. So thank you so much for that. Shamim, what is your take on what needs to happen in Kenya and across the region?
Thank you, Felicita. I think I'll start with echoing what Marion has just said about government just being accountable and doing the right thing, because yes, the civil society will add on to that, but I think also government needs to ensure that even within or during crisis, we still have strong fabrics and strong mechanisms that ensure, like no rights are compromised because 1, 2, 3 things are happening. I think the other thing also is to really capitalize on that almost everyone, quote, is going digital, and to really just think about how to make that even more accessible. For example, we have people who may not be able to access this space because, like maybe someone is deaf and they might not be able to access some information which is limiting to them when it comes to accessing full SRHR services. So just looking at now the world being at a place where we are almost at a standstill, but we are now all on the internet, almost all of us, but then how do we ensure that then we reach to everyone? And then I think the other thing also is to strengthen community systems, sort of. There's a time, I think in Kenya, or I might have had this from a training from ARASA, there have been discussions on community care on abortion. And so, beyond the hospitals, beyond the clinics, how do we strengthen communities to take care of people who have had access to abortion services, or people who have had abortion? I think that would be something really, really important. And then the other thing is also really to look at this time that SRHR is also, an emergency issue, and it's also a priority. So even as people are being given all this information that we have every day on our TVs, on our phones, everywhere about COVID, maybe that should also be packaged with important information about SRHR issues. In Kenya, currently, we are seeing the issue of early pregnancies or teenage pregnancies, being a very political hot issue, where we have even faith leaders discussing that in their mosques, in their churches, but then, also speaking about it from a point of information and a point of also responsibility. I think that would be a really great place to start. Thank you.
That's fantastic. Thanks for sharing, Shamim. I won't reflect on that because we are running out of time and I want you guys to have more time to speak. Tutu,
Yes, girl.
Your thoughts?
Yeah, so I have 4 points, basically. The first one is collaboration. I know that the previous speakers have also touched on the importance of collaboration. We've seen a lot of civil society organizations working together to hold government accountable, and we've seen a lot of violations being changed as well. With the beginning of lockdown and a lot of interruptions in services, a lot of those problems were resolved based on the actions of civil society organizations and them working together to try and address such issues. The second one is with addressing of oppressive laws. I know that some of these things happened around lockdown, but were not as a result of lockdown, but they still wins. For instance, Namibia has started conversations around the legalization of abortion. That's a plus. And again, that's another platform for other countries to learn and try to address some of the oppressive laws around the same time. We've seen a lot of focus on gender-based violence, sexual and gender-based violence in South Africa, and even draft bills being released for comment on how to address for victim support services. So those opportunities are worth taking, basically. The third one is the appointment of Dr. Tlaleng as the the new UN rapporteur for health. We can leverage on that as well, in that we now have one of our own in such a critical position, and she can be very useful for us in keeping the agenda of SRHR on the table. And the last one is adaptation. I've seen a lot of NGOs, obviously we've all been hit by COVID in multiple ways. However, we've learned to adapt to the new norm, and we've tried to use different and innovative ways of trying to address issues and ensuring that our work is also out there for the public to benefit from. So adaptation has been really key. The use of social media, the use of local radio stations to reach those that are not on social media has also been another way that we've never dreamt of working around, but is also very useful in trying to reach everyone and trying to ensure that we leave no one behind. I have a lot of points, but based on time,
I know.
I'd like to keep it there.
I know you, Tutu. You could go on forever. You have a lot of things to share and a lot of opinions, and love it. Love it. We love it. We just don't have enough time. And with that, I just want to reflect on some of the comments that have come in from our participants, and then also include some of the questions, which I will then bounce back to the panelists, and you can pick whichever of those you want to respond to. Interestingly enough, the majority of the comments and questions are around early and unwanted pregnancy, young people, youth, access to, comprehensive sexuality education, and how do we address the needs of young people during this time. That was very interesting. There was one comment that said, I think it was earlier on in the conversation, when someone was speaking about some of the challenges with access to contraception and unplanned pregnancies, just agreeing with that and saying, true, women, people couldn't access even contraceptives and ended up having unplanned pregnancies. And this is also going back to that crisis that's looming, the secondary crisis created by COVID related to sexual and reproductive health and rights. A question to all the panelists is, what realistic actions can we take as human rights activists and global citizens to change these human rights violations, to ensure women can stop suffering so much and that their rights can be taken care of? Then another reflection that says, since the outbreak of COVID-19 pandemic and subsequent precautionary measures against the pandemic, such as declaration and reinforcement of restrictions on public movement, stay-home rules, and closure of schools, colleges, and universities, thousands and thousands of schoolgirls have fallen pregnant and are not able to go back to school after the easing of the restrictions. Their right to education has been violated, as most of these pregnancies resulted from other triggering factors, including forced early marriages, and sexual and gender-based violence, including rape and incest. The question is, do we have any regional support or coordinated support to civil society organizations to enable them to carry out interventions to support the dropout teen mothers, either to help them return to school or to engage them in life skills and review SRH policies, which are restrictive on supply of SRH services, including contraceptives, family planning products to schoolgirls who are below a certain age, which creates a limitation. And you can respond to that from your perspective, not necessarily from the perspective of what kind of regional body exists to help to support that. So you can respond to that if you feel like, if it resonates with you. The other question is, what are you doing in terms of dealing with this issue of young pupils being impregnated? I mean, a child giving birth to a child. Then there's another question also about, teenage unwanted pregnancy or unintended pregnancy. Any highlights on levels of adolescent pregnancy in your region due to lack of SRH services during COVID-19 era? The question, I think there was from Namibia, is how can we scale up this effort from civil society to reach both in and out of school young youth with limited resources and probably during this COVID-19 pandemic? There's a question that came for the partner we had sharing from Malawi. It's just about how are you targeting young people who are key populations, in particular LGBTI and sex workers, female sex workers, with SRHR messages and access to SRHR services during COVID-19. Anyone of the panelists who can speak to that or have some experience with that, please do share. And then there's a member of parliament from Zambia, Dr. Christopher Kalila, who asks, what has been the impact of lockdowns and stay-home campaigns on adolescent sexual and reproductive health? So very much all the questions almost are pertaining to the needs of young people, adolescent sexual and reproductive health and rights. Do any of the panelists want to pick up on any of those questions? You can just kind of raise your hand and I can go to you first. But I'd also like to invite you then to give a few, closing remarks, pick up on any of the questions if you want to, or to give, your closing remarks before we move on and give some opportunity to our allies and our partners from SADC PF and UNFPA to reflect on what you've said. Tutu, do you want to share? Do you want to start? And then we can move on to Tadiwa and then to Marion and close with Shamim.
Sure, no problem. I realize that a lot of the...
Sorry, let's keep it brief, yeah? Let's keep it brief. We also want to hear from...
doing 10 seconds.
And I know you can do that. I know. I believe in you, Tutu. Go for it.
I guess I'll just reiterate what I said earlier, that the key is in activism. And again, it's been very difficult. It's been a major concern for some of us as well, how to reach adolescents at this time, because we also know of the non-existence of comprehensive sexuality education in schools. So understanding that they are having sex has been very, very difficult to reach them. However, that has led to us thinking of innovative ways of trying to address young people and adolescents. That includes, of course, the use of social media, of which not everyone is in, the use of radio stations, local radio stations, to deliver the SRHR information and ensure, the minute that we ensure that they have the information, then we have a higher chance of ensuring that they prevent the pregnancies, and also fighting against stockouts, contraceptive stockouts, which has been a problem in the region as well. So activism, ensuring that the word goes out in different channels, and also trying to address already existing problems that potentially, in fact, they don't necessarily potentially, but they do contribute to the rise of teenage pregnancies.
Thank you. Great stuff, Tutu. And you did it. Tadiwa?
Thank you so much. So I would like to respond to two questions. The first one was looking at the impact of lockdown and stay home campaigns on adolescents, sexual and reproductive health. Obviously, there's always a positive and a negative impact. Being the positive is the increased gender-based violence, unintended pregnancies, increased care work burden, mostly on young women within the homes. So probably those are the negative impacts of the lockdowns. The positive impacts, what Tutu has been talking about, whereby we are using social media to share information, conversations, and creating a global village where people could actually meet online and discuss like we are doing right now. And the second question with regards to issues of teenage pregnancies and going back to school. I would like to say congratulations to Zimbabwe. Our education amendment bill has now been in effect. It allows schoolgirls to accord maternity leave and return to the same school after delivery, and they can no longer be expelled. So yay to us for that. Thank you so much. So this is some of the, I think, work that's just being pushed during the lockdown and the stay home to say, you know what, this is something that's going to be happening. This is a lived reality that when schools officially opens, and schools are opening tomorrow for us in Zimbabwe, our writing classes, we're going to be having increased number of girls being pregnant. What can we do to probably address that issue? So yeah, in short, that's it for me.
Oh, fantastic. Thanks also for spreading the good news. We need more, good news these days. So thanks for that. Marion? And thank you, Marion, for responding to the question in the Q&A chat already. Thanks for engaging with that platform.
Sure. So the question is around adolescent sexual health and concern around teenage pregnancy. I want to turn that around and to say we need to work towards making our adolescents sexually healthy. And that is a very difficult thing, I think, for parents and teachers to turn it around and to actually accept that young people have a sexual health and we have to nurture it. That does not mean that they're going to have sex. That means that they're going to be framing their bodies positively. They're going to be learning about consent. They're going to be knowing about the names of their body parts so that they're able to say yes and no. And when they are ready to be able to access contraception and to have, to plan for pregnancies or to plan not to have pregnancies when they're ready. Now we know that the numbers are down for young people accessing contraception. So our health services are having to go to where young people are. And we need to stop policing that. And we need to make sure that if somebody wants contraception, we need to make sure that that's possible. And we need to support health providers getting stocks in place and also working out what is the correct contraception for them. In South Africa, 60% of contraception that's distributed is still the injectable. Now, that is a problem, that is a concern, particularly following the ECHO trial. And I think as groups interested in HIV, we need to question still why we're relying on depot when so many people actually want to move on from that. We need to be looking at other modern options that maybe are not of concern in relation to HIV acquisition. So what methods for young people are important? We also need to look at lubrication as well, not just contraception, so that they can have safer sex and pleasurable sex and not be exposed to sexually transmitted diseases too. So dual contraception options. And let me leave it at that. And I'm underlining that we need to look at keeping our adolescents and teenagers sexually healthy. And that doesn't mean that they're having sex, but they're learning to be able to practice safer sex and braver sex. Thank you.
Yeah, absolutely. I mean, and I think the underlying thing is also just destigmatizing adolescent sexuality. I think there's still so much work for us to do on that specific issue. Thank you, Marion. Shamim, you are the tail end of the panel. So please share your thoughts and some closing remarks before we move on to our allies and partners.
Thank you, Felicita. And I'll just say for the issue of teenage pregnancies, as I said earlier, in Kenya right now, it's a big issue. And for me, I'll just go back to the issue of knowledge and information sharing. Unfortunately, we do not have enabling legal environment where we can do work around comprehensive sex education. And that's a very big barrier, because even when we try, you know, it's considered to be an illegal issue. And so I would like maybe to ask the civil society together with government allies to just push for this, because it's really affecting the teenagers. But also the other thing is, as Thutu said, there's innovative ways of engaging the teens, social media, there's radio. And also I'd say the other thing is the percentage of teenage pregnancies that are not, you know, teen to teen pregnancies, but, you know, like maybe as a result of defilement. We need to also, like, you know, hold the perpetrators accountable. We need to ensure that there are platforms where we can hold these people accountable, because some of them are families, some of them are religious leaders, some of them are, you know, leaders within their own communities. And so we need to really hold people accountable when such things happen. And finally, I would say there is the need and importance of, you know, like the civil society working together with each other, so that we are complementing each other's work, ensuring that there is smooth referral systems, but also for us to unite and really just push on the government to take responsibility and to just do what, you know, we employ the government to do. Now we are seeing, for example, in Kenya, there has been a bill on, I think I'll just say the SRHR bill. And, you know, as a civil society, we need to engage more, we need to find more allies within the government, but also more importantly, to hold people accountable for what, you know, like for what they were employed to do. Yeah. Thank you.
Absolutely. And I see Tutu and others nodding to what you were saying. It's so important. I'd like to thank all four of you, my strong female lead panel. Whoop, whoop, Womandla. But thank you all so very much for sharing so generously. There were so many gems that I took away, and I'm sure that everyone who's been listening took away. And let's keep the conversation going. But thank you so much for helping us, you know, start to unpack some of these issues, and also learning from what you are doing in your context, what you think are priorities, and how you think we should approach the work, what needs to be done, etc. It really was a very rich conversation, and I thoroughly enjoyed learning from you. And with that, I want to invite Boemo, who is, you know, woman extraordinaire and the Secretary General of the SADC Parliamentary Forum. She not so recently took this position and has already been doing really amazing things, but was doing amazing things way before that, and really pushing the agenda of sexual and reproductive health and rights, and supporting parliaments and parliamentarians to be able to fulfill their mandate as it pertains to realization of sexual and reproductive health and rights. Boemo, before we start, just to say, I appreciate the work you do. We appreciate the work you do. I don't know if I could do the work you do, but I wanted to just hear your thoughts on everything that you've heard this afternoon, and some reflections on the role of your institution, what you have been doing, what you and your partners have been doing, and what you think other stakeholders should be doing to ensure uninterrupted access to SRHR during the COVID pandemic. Please.
Thank you, Felicita. The feeling is mutual. I've always appreciated what ARASA does and what you do. And let me salute and appreciate the members of parliament who are on this particular webinar. And this goes firmly with what the SADC Parliamentary Forum does greatly. And the forum has always considered sexual reproductive health and rights as a human right and is therefore not an option. All parliaments need to implement sexual reproductive health and rights under the umbrella of the right to health and with the necessary nexus drawn with the right to physical integrity and the right to life. Therefore, sexual reproductive health and right is considered to be the very essence of human existence by most parliament. And I say this with conviction because before I came to speak to you today, I surveyed at least 12 parliaments in the SADC region to look at what is it that members of parliament are saying or doing within the context of ensuring that we sustain sexual reproductive health and rights services during these trying times of COVID-19 pandemic. Let me also just highlight that it will be very interesting for all of us in this particular webinar and including our partners who we work with at national level to put in context what is currently going on in Parliament. Because I know that there are mixed feelings around what should really be government doing. What should parliaments really be doing that really changes everything around? Given being locked up, the anxieties that are there and the mental health, we don't have longevity to appreciate things that we ordinarily did appreciate before. And I think this is very, very important for you to realize that it is necessary for parliaments to innovate and we should not apologize for that. It is very important that parliaments continue to implement their mandate in one form or the other. We have observed that what has currently been happening in most parliament, we are in what one would refer to as a crisis recovery planning process. Most often you find that our governments and parliaments are focusing on delivering the historically unprecedented levels of relief that are providing lifelines to individuals and trying to rescue businesses to remain solvent. This is a very complex choreography that any government can do when they wake up and they are thrown out of the window. All of a sudden, they have to put aside certain things that they've been focusing on, and now they have to look at what is required to open the economy to function, what is required to minimize the resurgence of the virus, what is required to open or close schools. And this has underscored what we see as a rollback or a pause in the plans of most governments, or a pause that is manifesting in parliaments being seen to be in the back burner in most of our countries. However, I can assure you that parliaments are deliberating on some of these issues. You can go on any website of the parliament of your country or ask for questions that members of parliament have been asking. We have parliaments from both sides of the aisle, those from the ruling and opposition. Sometimes because of numbers and other political power relations, they may not go through in the manner that we all expect. However, it's important to state that all members of parliament, all local leaders, together with civic communities like yourselves, are very critical in shaping an inclusive recovery process in this COVID-19 process. And therefore, we are looking at very serious and unprecedented funding shortfalls in most of our governments. I've heard you talk about non-essential, essential. I've heard you talk about lockdown and non-lockdown. You will realize that this is all a pause that government has, the space that government is in order to say, should we halt this and not halt this? And we've seen debates like, I'll quote one member of parliament in Zambia, Dr. Shanda Jonas, who was actually talking about if government is not incisive in what it does, the economies are going to collapse, the infection are going to go beyond what it is right now. I don't want to go further into talking about what you've talked about, but I'm agreeing with you that this is something that we need to be able to encourage parliaments, despite the impediments that we have already spoken to right now. There's still need to ensure that sexual reproductive health and rights continues to be implemented without ifs and buts. And therefore, this is your role. Quickly, because we want to save time, let me look at the key question that I think is quite relevant in this context. What is the role of yourselves or the various players or stakeholders to ensure the uninterrupted access to sexual reproductive health and rights during COVID-19 pandemic? One, I think we must look at something like this in summary. We have the upstream, where we have policy and decision makers that must be engaged, that must be held accountable. At the meso level, we have the service providers framework. This is where access is critical in what we're talking about. And this is where implementers and advocates like yourselves need to come up with concerted strategies to make sure that we work towards dealing with this issue of uninterrupted access to sexual reproductive health and rights. Downstream, we have communities who require these interventions and rely on all of us. And I must stress that we all need each other. You cannot deal with one leaving the other, then your work is unfinished. Point two, how do we ensure uninterrupted services? This requires that we must be able to anticipate what next. We must be able to sharpen how we advise, and we must synchronize support across all these layers that I've just spoken of. I'm happy to hear some of you say we've come together as coalitions. We've looked for partners that ordinarily we did not work with. And this is the support that is important. It's a support that's equally important for policymakers because Parliament itself has not been spared. Governments have not been spared. Clinical teams have not been spared. The grassroots has not been spared. And we need to look at how we can work around key issues that we may not have worked on before. How do we enhance service patient communication regarding access? How do we look at and put together the client experiences? How do we document that so that it can inform experiences? How do we exploit teleconsultations? Somebody mentioned something about telemedicine, and I think this is where civil society should lead in consultation with our parliamentarians and policy members. We need to think about how we can update our policies. COVID-19 has thrown out a lot of what we thought we knew we can do. It also means that even at our level where we work in our organizations, this also has actually happened. We've been updating our business continuity plans, and therefore this should also happen to government. We need to update regulations that government is using to implement our services, and we need to look at models to advance decentralization and distribution. We've talked about lockdown, where people are left in the rural areas. This is a time for us to look at decentralization, distribution models, and how we can leverage on these. This is quite important because we need to look at how do we, even under SRHR, look at multi-mouth dispensing. How do we make sure that we don't affect ART, TPT, and CPT to address adherence, and also retention, so that not everybody is affected because now things are not essential as we had importantly thought before. And let's communicate new ways to our grassroots. Let's communicate new ways to our communities so that they can help policymakers and parliaments to monitor and scale up interventions in this regard. The third intervention is strengthening collaborative relationships. I won't say much about this because all of you have underscored the importance of collaborative relationships. It's very important that sexual reproductive health and right movements, gender and human rights activists, and advocacy communities have positive returns in agenda setting, which means you must form coalitions. Otherwise, you can speak from every corner. This will not have positive returns. We need to collectively look at language, collectively look at stereotypes. We need to challenge and change unequal power relations between men and women, and look at the negative attitudes that have been there before and discriminatory practices and leverage on that so that we can protect the vulnerable groups that we've been talking about, the young children. In the process, we should be able to build interlinked foundations which have a transformational impact beyond COVID-19 and into the future. So these are lessons that we should look at. And what could be transformational in this respect? Legislative action. We can talk the whole day today for what purpose? For a conducive policy environment. Parliaments can talk the whole day, and this is what they had to do, but at the end of the day, we're looking for legislative action. So let us strengthen legislation around sexual and reproductive health provisions. Let us look at domestication of international and regional instruments that support sexual and reproductive health and rights, and the elimination of violence against women and girls. This is very important. I'm not leaving out the boy child, but I'm underlining this based on evidence. We need to work together to increase access to sexual and reproductive health and rights. You've spoken about girls and women's life cycles. You've talked about advancing the girls' right to education. We should also not forget women's economic and political empowerment. Currently, the hardest hit are women who cannot go to work because of lockdown and who have the multiple roles that we're all aware of. At the political level, there are very few women represented in Parliament. And this is an area that we have to look at as civil society, including an increase in women's participation in position of leadership. This is very key in meeting the unmet needs and developing resilience of communities and nations. Talk of women's leadership, it is a different type of leadership, and I believe that as part of what we do, must invest in some of these things. It will help us focus where progress has been slowest. It will help alleviate the multiple discrimination and disadvantages that we see. We cannot leave girls and children with disability or special needs unattended to during this particular period. Parliaments are asking these questions. Parliament needs your support. Find these members of Parliament who've been asking questions and form coalitions with them. We must not leave anyone behind, whether it is a girl child, a woman, a boy, or a man behind. The last point that I'd like to raise is to leverage opportunities provided for in the political declaration at all levels. The political declarations made at the United Nations General Assembly in 2016 in particular on HIV and in 2019 on universal health care are very important for us to reflect on because there's very instructive guidance in these instruments. It speaks for strengthening people-centered health and social systems. This has become very critical during COVID-19. It talks about meeting commitments to deliver primary health care as a cornerstone to achieving UHC. And this is quite important. Protection and promotion of sexual reproductive health and reproductive rights in accordance with the program of action of the ICPD and the Beijing Platform of Action, among others. So as we do what we do, we have a basis. We should not be apologetic. And we've talked about opportunities to collaborate, and let me focus on these opportunities with the institution of Parliament as I end. We need to encourage increased budget allocation for population and development and sexual reproductive health and rights. We need to link population and development agenda to the SDGs and better monitor progress. We need to support capacity for effective monitoring and development instruments and policies. We need to end preventable maternal death. No woman should die giving birth. To fulfill these unmet needs for SRHR and family planning, we must advocate, we must engage with our policymakers. We need to end gender-based violence and all harmful practices. We must address the needs of young people. We must ensure timely humanitarian responses, and we must strengthen the capacity of parliaments to act, to be accountable, and to commit politically to why we voted them in office. Colleagues, members of Parliament, I think I've said what needs to be said, and we look forward to working with you at the SADC Parliamentary Forum. Our doors are open. we have a passion around issues of development, around issues of our population. So we want to create a communication cell with each one of you. Would like us to act as a buffer to facilitate interaction with members of parliament and citizens. And in all cases, parliament should be perceived as an open platform where citizens and civil society organizations can participate through their elected representatives and are able to convey their grievances and proposals without any hindrance. With this, colleagues, I wish to thank you for your kind attention.
Wow, Boemo, what more is left to say after that? We must just close the session and move on. Innocent, sorry, Boemo has set the bar very high, but I know, just to speak to the commitment of SADC-PF, that you've always shown to not only the issues of SRHR and how much SADC-PF has championed that with parliamentarians in the region, all the work that the honorables have done in their own communities. We don't take it lightly because we know that it's not always the easiest agenda to champion. But also your commitment to partnering with civil society and with communities and championing the issues of marginalized communities has always been commendable. We do appreciate you, and we appreciate what you bring and what you have always done and what you stand for. Thank you so much for the partnership and for joining us this afternoon. Innocent is the SRH and HIV advisor at the UNFPA regional support team for East and Southern Africa, and is the only male in the webinar joining us this afternoon. So the bar has been set high, not only by the women that have gone before you, but the fact that you're also our closing speaker, but also speaking to the commitment of UNFPA to the issues of SRHR, but also to collaborating with civil society, and also, recognizing that we need each other to realize SRHR in Southern and East Africa. Thank you so much for joining us, Innocent. It's always a pleasure engaging with you, and we do appreciate your commitment. But please do share your reflections on everything that you've heard this afternoon.
Thank you very much, Director of Ceremonies. Indeed, I feel terribly marginalized being the only man, but I shall try to survive, and I'm experiencing what women have experienced all these years, so it's fine. I'll survive. I will engage at 4 levels in terms of what I want to address. I want to reflect, to share with you briefly what we stand for as UNFPA. I then want to confirm what the 4 panelists, including the 5th, have sort of reflected on in terms of the impact of COVID to SRH. And then share with you in a minute also what we are doing, we are trying to do as UNFPA in the region, and then make some concluding remarks. As you may be aware, UNFPA is the UN SRH agency. Our focus, particularly in Eastern and Southern Africa, is really to achieve 4 main things. First, we want to ensure that we end all preventable maternal deaths. We really want the issue of reproduction to be an enjoyable experience rather than an experience that brings misery. Secondly, we want to end GBV and harmful practices, including challenges around child marriages, issues around female genital mutilation. The third area that we are concerned in as UNFPA in our region is to end unmet needs for family planning. We do believe that individuals should have children when they want to, and whatever number that they want to, and that family planning should assist to those individuals to realize their objective. The fourth area that we are focused on as UNFPA in the region is really to try and assist the 23 countries that are working in to end sexual transmission of HIV. So focusing on those four areas, we have been obviously concerned that the advent of COVID has sort of undermined those four areas that we are trying to focus on, and that our commitment to end those four tragedies by 2030 may be compromised. And the pathways in which COVID-19 affected those four ways are as follows. First, we know that a number of our countries put down the lockdown system, which was necessary to contain the spread of the virus. But there were unintended consequences. First, we know that with countries defining what was essential health service, a number of preventative services were actually excluded. And therefore, things like even prevention of HIV services, they were excluded. Some of our countries actually were specifically even saying, in terms of their policies, that they will not encourage people to come for things like condoms to clinics. Another implication of the lockdown was that because of the COVID, a number of health workers were repurposed. So instead of them focusing on the general SRH, some were taken away to actually assist in the emergency areas. So that obviously affected the supply side. Another factor which affected the supply side was that health workers themselves actually, they got ill, and some unfortunately passed on. And that also affected the input or the service that we anticipated in as far as delivery of SRH services are concerned. But also from the client side, we are aware that there were people who were at risk of those four areas that I talked about that decided not to go to the health facilities because they were worried about the possibility of actually contracting the virus themselves. So all these factors contributed negatively to the four areas or transformational goals that as UNFPA we are committed to, which are all part of the SRH. So even though at the moment we don't know the magnitude, but there are indications through our monitoring systems that things have not moved in the direction that we wanted. So what have we been doing? Well, basically as an SRH agency, we've actually been advocating to our country offices, to our partners, to innovate and ensure that access to SRH is still maintained. And I'll give you interesting examples of things that were happening or are still happening. First, like all of you indicated, we promoted strategic partnership within the UN. For instance, in Zimbabwe, UNFPA collaborated with World Food Programme, which was, as you know, World Food Programme was supplying food to communities that are most affected. When we realized that the numbers for people accessing family planning was rapid, we collaborated with World Food Programme and ensured that condoms were part of the package of food that was being delivered to various communities. So in that way, we managed to still make condoms accessible to a number of people. In Uganda, working with young people, we managed to expand or leverage on online services to ensure that young people were actually reached through online services. In some countries, we actually recalibrated the delivery services. We realized that people could not go to the health facilities, so we took health facilities to the people. In Namibia, for instance, we supported mobile clinics to actually go to the communities to deliver SRH services. Another intervention that was quite interesting, that is still evolving, is that we also advocated for integration of the COVID response with the HIV response, so that they are not seen as things that are contradicting each other. And so, for instance, in Malawi, we worked with young people to sort of integrate COVID messages with HIV prevention messages in the area of Mangoti. But we also noted as UNFPA that different populations were affected differently. And the populations that we refer to as key population in HIV appeared to be one of the most affected. And I can give an example just of sex workers. Sex workers were not only denied income, when most countries were beginning to mitigate the impact of COVID through giving food parcels, in a number of countries, sex workers were excluded because they are not recognized as working. So basically, their livelihood was seriously compromised. At the same time, their safe spaces for accessing SRH were also unavailable. And the same can be said about the MSM, transgender, and other communities. So we also tried to innovate and see how best they could be reached. For instance, in Lesotho, there were special initiatives along the borders where some of the key populations are found to actually extend services to them. Another way in which we did this, or we are doing this, is that we sort of promoted social contracting by engaging services that will not necessarily normally engage. For instance, in Uganda, there is a common mode of transport that is called border. Those that have gone to Uganda or Kenya, they may be aware of the borders. So UNFPA, together with civil society organizations, collaborated with the borders to actually deliver SRH commodities, including condoms and other related products. So these are some of the initiatives that were forced to think outside the box to ensure that we mitigate the impact that were being felt by different populations. So really our key message is that I think as different stakeholders, we need to always think about the possibilities of emergencies and put in place plans of how to deal with such situations. We are in a region where humanitarian crises are common. So by now, really, we should be having a strong mechanism in which we can anticipate some of these challenges and have mechanism to contain them on time, rather than to respond in a panic mood. I think my last message, Director of Ceremony, is that one of the important lessons that we have also learned during this COVID is that we may need to rethink the way we do business. Just imagine that we have now successfully conducted a very productive meeting without having to fly to Cape Town to attend to an ARASA meeting. So maybe the silver lining is that this may encourage us to even do business more efficiently, especially given the limited resources, and use the saved resources to actually make a better impact on the population that we serve. The last thing is that this epidemic or pandemic has confirmed that schools are actually a protector of SRH. We have seen that by closing schools, we have had thousands of young girls getting pregnant. You can also imagine the number that has got infected by HIV. So one of the things that I think should be a common agenda for all of us, including members of parliament, is to ensure that the girl child goes to school until high school. That way we'll be protecting her from the challenges associated with SRH that they may confront prematurely. I thank you.
Wow, Innocent, you did not disappoint. So much food for thought at the end of what's been a very, very rich discussion. And it just goes to show there's so much that I wanted to pick up on the things that, you know, you reflected on and some of the examples you shared of, you know, how Unfpa has been adapting to support communities and support countries to ensure the access to SRHR during the COVID pandemic. But I think the main takeaway that I took from your input was really that reflection about we need to be better prepared, because as a region, we have so many humanitarian crises facing us that we should not be caught as unaware as we were caught by COVID-19. I really appreciate you know, you sharing your sentiments, sharing the experiences of Unfpa, and also for your ongoing leadership as an institution in the area of SRHR, and also for your commitment and partnership with civil society. You always come when we ask, and we appreciate that commitment and yeah, the sense of camaraderie and knowing that we are truly in this together. With that, we have come to the end of the session, and one other thing that I have realized as the moderator for now the second of these webinars is that we are overly ambitious in thinking that it will be an hour-and-a-half long session, because even after all this time, we still have more than 30 people staying with us throughout the conversation, and that's not even counting the panelists and the ARASA team. But it shows that there's such an interest in having these conversations as a collective and saying, what are we learning? How can we use this? And how can we collectively do better to protect rights in the response to COVID and make sure that the lessons we've learned from other pandemics, including HIV, Ebola, etc., are included in this response to COVID, and that the gains that we've made so far are protected. We are so excited for the next 2 or 3 webinars that are coming up, and I will just brief you on the topics for those, and then, you know, conclude and close the session. So in 2 weeks, on the I believe the 24th of September, we will be discussing the issues of accountability in the context of the COVID-19 crisis. This is going to be another one of those webinars that you don't want to miss, because we will focus on allocation and accountability for financial and other resources in particular during that webinar. So we'll have a lineup of very, very interesting speakers, but also look forward to hearing from you and everyone else that joins us about what's happening in your country in terms of accountability and the use of financial and other resources for the COVID-19 response. After that, 2 weeks later, we will have a webinar on policing and enforcement of COVID-19 regulations, focusing on the impact on marginalized communities and access to justice. Another very, very exciting topic. You cannot imagine how excited the ARASA team is to pull those two webinars together, but also the third one and final one that will look at the gendered impact of COVID-19, which will also tie together a lot of the strings that have emerged in the conversations we've had about the impact that COVID-19 has had on women and other marginalized communities and non-conforming communities, etc. So we really are enjoying these discussions. We look forward to the next ones. But I would like to bring this specific one to a close by thanking very sincerely, again, the speakers who have joined us and shared their experiences and their perspectives with us so generously. We also want to thank everyone that has joined us, from all corners of the world, particularly those who have joined us from Southern and East Africa and shared their perspectives and questions. Thank you so much for joining us. We enjoyed having you. The interpreters, again, thank you so much for assisting us to communicate and accommodating our colleagues who come from Lusophone and Francophone countries in the region. And then finally to the ARASA team, a big thank you for pulling this together. And for Soraya, who's been the lead person specifically on this webinar. Thank you, Soraya. Also Hedjin, Bruce, who was the lead person on the previous one. But thank you to the ARASA team for all the work you've done ahead of this webinar, but also behind the scenes. We appreciate it. And with that, I wish everyone a good day further. Goodbye.
Thank you. Goodbye.
Thank you for an excellent session. Bye-bye.
Bye.
Thank
Goodbye.
you, everyone. Goodbye.
Thanks. Goodbye.
Thank you. It was beautiful.
Thanks. All right. Bye.